On va faire en anglais étant donné qu'on a des personnels de l'étranger. It's my pleasure today to introduce our today's speaker, Jean-Charles NAULT. Jean-Charles received his MD and PhD from the Paris Descartes University and is currently a professor in the liver unit at the Avicenne Hospital in Bobigny. He conducts his research in the laboratory of functional genomics and of solid tumors led by Jessica Rossi at the Cordelier Research Center in Paris. So over the past 10 years, he has been serving several journals in the field of hepatology as editorial board member, and he's currently an associate editor for the Journal of Hepatology. So Jean-Charles' research is dedicated to translational research in the field of liver cancer, and he's particularly interested in the identification of new driver genes, new therapeutic targets, and prognostic biomarkers. Jean-Charles has contributed many seminal papers to the field over the past years, and he also got several awards, including the prestigious Young Investigator Award from the EASL in 2017 and the Rising Star Award from the United European Gastroenterology Association in 2019. So it's really an honor to have you today, and Jean-Charles will now present his talk about the genomic and precision medicine in hepatocellular carcinoma. And please don't hesitate to either type your questions in the chat or to raise your hand and then switch on your camera to ask the questions after the seminar. So Jean-Charles, please.
Okay. So I will talk about genomic and precision medicine in HCC. So this is my conflict of interest. So the first part of my talk will summarize a little bit the genetic landscape of hepatocellular carcinoma, the biomarker in management of HCC in 2024. So it will be very short because there is very few, and future potential prognostic biomarkers, theranostic biomarkers, and finally, I will talk a little bit of liquid biopsy. So what about the genetic landscape of HCC? So as you know, and as an introduction, HCC is third cause of cancer death worldwide and are developed on cirrhosis for most of the cases, 90% of the cases, and sometimes on non-cirrhotic liver, but some related to various risk factors like HBV, obesity, or malignant transformation and adenoma. But usually it's on cirrhosis through a multi-step process of carcinogenesis with occurrence of low-grade dysplastic nodules, thus high-grade dysplastic nodules. It's a multi-step process. And finally, malignant transformation and HCC. And the underlying liver disease, cirrhosis, could be related to HBV, HCV, alcohol, and obesity in most of the cases. So when you analyze one HCC, each HCC is a unique combination of somatic genetic alteration, like every cancer. And if you analyze HCC of 4 to 5 centimeters, you have 40 to 60 somatic genetic alteration in coding sequence per HCC. And if you want to identify only the mutation in genes that are important in carcinogenesis, that are known to be the driver genes, there is 2 to 6 driver genes mutated in each tumor. It means that most of the mutation are called passenger mutation because there are no functional consequences and no involvement in liver carcinogenesis. So 2 to 6 driver genes in each hepatocellular carcinoma. And here I put the genetic landscape of HCC with, here it is only the driver genes, so that are recurrently mutated in HCC, important for carcinogenesis. And they belong to, we can say, 6 major pathways. The first one and the most important one is related to telomere maintenance, with the most frequent genetic alteration is a mutation in the TERT promoter, 40 to 60% of HCC. After you have mutation in cell cycle genes, and it's a very well-known tumor suppressor genes that are highly mutated in HCC, that is P53, but more rarely you have CDKN2A retinoblastoma genes that are mutated. And after you have beta-catenin with a well-known beta-catenin activating mutation that are non-oncogenes, so it's a Wnt beta-catenin pathway. You have also mutation in other pathways that are less frequently mutated, but that you can find it in HCC, such as oxidative stress pathway and AKT-mTOR pathway, and also mutation in epigenetic modifier genes. It is the middle in the, of the slide and the lower part, such as mutation in RED1A, RED2. So it's a genetic landscape. There is a lot of mutation. There is some of them that are highly recurrent, like TER promoter mutation, but it's more complex than that. It's already complex because there is a lot of different pathway alterated with genetic alteration, but also there is association with risk factors. I come back, you know that here you have different risk factors of chronic liver disease, hepatitis B, C, alcohol, metabolic syndrome, and when you analyze the genetic landscape and you come back to the risk factor, you have an association between the type of risk factors and the mutation that you observed. And just some example, it's not exhaustive one, but when you have hepatitis B, you have more P53 mutation and MLL4 mutation. When you have a alcohol-related HCC, you have more TER promoter mutation, beta-catenin, and RED1A. And in contrast, there is HCC of a known etiology without developed on normal liver, and there is less TER promoter mutation in this sample. So there is a correlation with the risk factors. And so there is risk factors and there is a multi-step process of carcinogenesis. And you know that most of HCC are developed in on cirrhosis. And one of the main features of cirrhotic hepatocytes that there is short telomere at the end of the chromosome. And you know that telomere are repeated DNA sequence that are at the end of the chromosome, and that allow when you have cell division and cell and DNA replication to avoid the loss of functional genes, because when you have DNA replication, you have the loss of the end of the chromosome. And telomere, it's repeated region at the end of the chromosome that protect the coding sequence from when you have DNA replication. And the main one of the main hallmark of cirrhosis is telomere attrition and decrease of telomere at the end of the chromosome, and it's related to cirrhosis occurrence, but also due to aging. So you have short telomere in patients with cirrhosis in the liver. And to allow proliferation, you need to have telomere, because when you proliferate, you replicate your DNA, so you shorten the extremity of your chromosome, and if you have no telomere, you lose coding sequence at the end. So telomerase, the enzyme that produces telomere, reactivation is required for malignant transformation at a very early step of carcinogenesis. And we discover in the lab that the main mechanism of telomerase reactivation was mutation in the TER promoter that occurred around 50 to 60% of HCC. So the mutation in the promoter of TERT allow binding of ETS, CCF transcription factor in the TER promoter and activation of TER genes transcription. There is also viral insertion. It was well known more than 30 years ago by HBV that are inserted in the promoter and activate the expression. There are also rare cases of TERT amplification and TERT translocation. So the mechanisms are different, are exclusive together. You cannot have TERT promoter mutation at the same time via viral insertion or a TERT amplification, but it is required. In most of the cases, you need to have telomerase reactivation at early stage of carcinogenesis. So it's a multi-step process. First, telomerase reactivation with TERT promoter mutation, and you can see that you can identify TERT promoter mutation in pre-malignant lesion, low-grade dysplastic nodules, 6% of mutation, high-grade dysplastic nodules, 10 to 90% of mutation, and after 60% of HCC have TERT promoter mutation, and almost all telomerase reactivation. And it's allowed to maintain the telomere length to avoid decrease of telomere length due to cell replication. So it's a gatekeeper that it's called in oncology a gatekeeper, and it's mandatory telomerase reactivation, and most of the time, due to TER promoter mutation, is mandatory to have malignant transformation. First step. And the second step, you have accumulation of overmutation in driver genes. These driver genes that I have put here in this this one. This is a driver gene that are mutated in a second step. After telomerase reactivation, you have mutation in other driver genes, beta-catenin, P53, RED1A, AXIN1. So telomerase reactivation through TER promoter mutation, early step. Second step, acquisition of genomic diversity, TP53, beta-catenin, RED1A. And at the end of the process, when you have metastasis, because we have analyzed genome of metastasis of HCC and of advanced hepatocellular carcinoma, you have accumulation of TP53 mutation, more TP53 mutation in advanced stages, and mutation in retinoblastoma 1. So, and that are key pathway that control the cell cycle, P53 and retinoblastoma. So you have huge dysregulation of pathway that control the cell cycle and high proliferation in advanced hepatocellular carcinoma. So this is the genetic landscape, basically. And now I will go to a little bit of translation. So first, biomarker in management of HCC in 2024, okay? So it's a little bit a pity, but currently the only biomarker that have been validated is alpha-fetoprotein, serum alpha-fetoprotein. That is a biomarker that has been discovered in the middle of the 70s, so in 74. So it was identified in 74, tested for HCC screening. It was controversial for assessment of prognosis and to prediction of response to treatments. So for HCC screening is not very good. For prognosis, it is okay, it is good. So now it's used to identify the patient at low risk of recurrence after liver transplantation, on high risk of recurrence after liver transplantation. It is called the AFP score. So it's a combination of diameter, number of nodules, and the rate of serum alpha-fetoprotein in patients that could be treated by liver transplantation. And if you have a low score, AFP score, you have a good prognosis. And when you have a high AFP score, you have a poor prognosis. And now you cannot be transplanted in France if you have a high AFP score. So it was for prognosis. And predictive of response to treatment, there is only one randomized controlled trial that has been stratified according to a biomarker. It was serum alpha-fetoprotein in a patient with high serum alpha-fetoprotein, more than 400 nanogram per millimeter. When you used an antibody against VEGFR, that is an anti-angiogenic treatment, ramucirumab, you have an increased overall survival against placebo. But you can see only 1 month. So the only biomarker, because it didn't work when you have a low serum alpha-fetoprotein. So in high serum alpha-fetoprotein, it increased a little bit your survival in this randomized controlled trial, but it's not very impressive. And additionally, we don't know why this patient benefit a little bit more with high serum alpha-fetoprotein, benefit a little bit more of this anti-angiogenic treatment. So it's not very exciting in 2024, the biomarker in hepatocellular carcinoma. So there is some limitation that we know. First, the histology is available in the randomized controlled trial of systemic treatment in less than 40% of the cases, because we can use what we call the non-invasive method based on imaging to reach a diagnosis of HCC. So biopsy, histology is not required in most of the cases. So we have not sample. So histology in most clinical trial, now it's a little bit moving differently, but in the first clinical trial, histology was not mandatory. Some of clinical trial have no biobanking, and also there is a huge heterogeneity worldwide in terms of risk factor on underlying liver disease. So if you do a randomized control trial in China, it's not the same that in Europe or USA. So you have to take into account, as I previously described, the risk factor of the disease, and the risk factor of the disease depend on the country. So I will discuss two types of biomarker derived from molecular and genomic analysis. First, about prognosis and after prediction of response to treatment. I will not discuss the diagnosis; it's a different part. But I will discuss prognosis and prediction to response and treatment, and two types of sample that I want to discuss. First, the analysis of the tumor, and second point, the analysis of the blood, of the plasma. So first, the tumors. So what about prognostic biomarker? So what we could say is that when you have sometimes there is a difficulty to do a diagnosis of a small hepatocellular carcinoma using the imaging. So you do a biopsy, and the biopsy sometimes, not so frequent, but the biopsy answer it's not an HCC, but it's a pre-malignant nodules. Low-grade dysplastic nodules, high-grade dysplastic nodules, and we didn't know what are the risk factors of the malignant transformation based on histology or tumor size in early hepatocellular carcinoma. And as I previously described, we identified in some cases in these pre-malignant nodules TERT promoter mutation, and we know that TERT promoter mutation are highly involved in malignant transformation. So if you do a sequencing of pre-malignant nodules, and you have a TERT promoter mutation, in my mind, I think it's good to treat this patient because the risk of malignant transformation is high. So it's a way to assess the prognosis, the risk of transformation when you have a diagnosis of small low-grade dysplastic nodules or high-grade dysplastic nodules. It's not so frequent, but two or three, we have, I think, 2 or 3 patients per year with a tumor biopsy that answer. I don't think it's an HCC, it's a pre-malignant lesion. So first, it's a way to stratify the risk. The second way to assess the prognosis is to use what we call the genotype-phenotype classification of HCC. That is related to the tumor heterogeneity. Across tumor, it's not the intratumor heterogeneity, the heterogeneity across the different type of HCC. So it's a transcriptomic classification that identified different subgroup that we call G1 to G6, G1 transcriptomic subgroup, G2, and so on. And interestingly, when you analyze the transcriptome of the HCC, you have a homogeneous subgroup at the transcriptomic level that are associated with specific genetic alteration. For example, G5, G6 is beta-catenin mutated, G1, G2, G3 are P53 mutated, G1, G2, AXIN1, BAP1, that's a rare mutation that are G1, and it's associated sometimes with risk factor, HBV, it's more frequent chromosomal instability, AXIN1 and TP53, and it is also associated with pathological features. For example, beta-catenin G5, G6 on the lower part of the classification are HCC with cholestasis and glutamine synthase accumulation in the hepatocyte at immunohistochemistry. Steatohepatic HCC, a subtype of HCC, are more of G4. And an interesting subtype is G3, macrotrabecular massive hepatocellular carcinoma in the middle. That is interesting because you can identify it at histology because it's called macrotrabecular massive because the trabecular area of malignant hepatocyte are very large and that are closely associated with molecular features, dysregulation of cell cycle genes, neuroangiogenesis, FGF19 amplification, TSC1, TSC2 mutation, and Julian Calderaro and Marianne Ziol described that this subgroup of tumors are of poor prognosis. On the right, you have HCC treated by radiofrequency ablation. So it was on tumor biopsy. When you are in red macrotrabecular massive HCC, you have a low recurrence-free survival, and on the left part, HCC treated by liver resection. So also when you have a macrotrabecular massive HCC, you have a poor recurrence-free survival. So you have a genotype classification, phenotype classification, G3 molecular subgroup, FGF19 amplification, macrotrabecular massive HCC at histology, and poor prognosis. Another way to assess the prognosis is to predict recurrence and survival based only on the transcriptome. And it's an example of what we have done 10 years ago. It's molecular signatures using 5 genes, TAF9, ROM3, HN1, KRT19, and RAN. You use the logarithmic predictor, and it's classified in good and poor prognosis. It was HCC treated by liverization. It predicts survival and overall survival. It's only based on transcriptomic analysis. And it was validated in radiofrequency ablation, so on tumor biopsy. So you could do a molecular biology on tumor biopsy, or for radiofrequency ablation, it predicts survival. And in intermediate advanced stages, in patients with metastasis under systemic treatment, it's also predictive of survival. So you could use transcriptomic analysis on liver sample, but also on tumor biopsy, it's possible. Okay, so this is prognosis. And what about diagnostic biomarkers? So here I put the landscape of systemic treatment for advanced hepatocellular carcinoma. So it's hepatocellular carcinoma with portal vein thrombosis, metastasis, and currently the first-line treatment is a combination of immunotherapy, anti-PD-L1 atezolizumab, with anti-angiogenic treatment, anti-VEGF bevacizumab, or a double immunotherapy, anti-PD-L1, anti-CTLA-4, durvalumab, tremelimumab. So it's first line. In second line, we use tyrosine kinase inhibitors, so sorafenib, lenvatinib, regorafenib, cabozantinib, that are not very well tolerated and with a poor anti-tumor efficiency, at least for most of the patients. So the question is our ability to predict the response to treatment, and when the usual treatment don't work, if we could identify new therapeutic targets. So what we know, we have the genetic landscape. We know that the most frequent genetic alteration, TP53, TERT, ARID1A, are not druggable. Currently, in 2024, there is no drug to treat these frequent genetic alterations. There is no prognostic molecular signature validated in prospective clinical trial. It's only retrospective. For prospective clinical trial, most of the time there is no tumor sample. And there is no biomarker-guided therapy used in clinical practice except serum alpha-fetoprotein for ramucirumab. So it is the current knowledge. So what could be done in the future? There is some data that could suggest that maybe biomarker-guided therapy could be useful in some patients with HCC. The first proof of concept was FGF19 FGFR pathway in HCC. So in a small subset of HCC, you have an FGF19 cyclin D1, because it's the same locus as two genes very close, amplification. It's around 5 to 10% of HCC. It's associated with poor prognosis because it's a G3 transcriptomic subgroup. It's 5 to 10% of HCC. So it's poor prognosis. It's a ligand that's bind to FGFR4, as you can see, and activate different pathway downstream. And it was a proof of concept. You can see here it's one of our sample. You can see the amplification of the FGF19 or cyclin D1 in one HCC. And there is an oral FGFR4 inhibitor in a phase 2 clinical trial that showed that there is only response when to this FGFR4 inhibitor when you have positive FGF19 HCC. When you are negative FGF19 HCC, you have no response. So it was a proof of concept, but the rate of response was not very high. Usually, when you do biomarker-guided therapy, you expect 40% of response if you have a biomarker with a good drug. Here it's below. So why you have a low rate of response? Because some patients developed after a response or very fastly under treatment, mutation of resistance to FGFR4 inhibitors. And it was an example of one of the patients of this trial that have an FGF19 amplification. They used fisogatinib, FGFR4 inhibitor. They have partial response and tumor progression, and they do the biopsy of the tumor progression. And there is a new mutation that occurred in the tumor that was the FGFR4 mutation. So, and it was a mutation that occurred in the kinase domain. And the kinase domain is a domain where fisogatinib bind to have anti-tumor activity. So this mutation impaired the binding of the drug. So they could, so they used in vitro, it was not in patient, a pan-FGFR inhibitor that inhibits different parts of FGFR and different part of the kinase domain to reverse this mutation and the resistance to treatment. So maybe the low rate of response is due to accumulation of early genetic accumulation of early mutation of resistance, and could be bypassed by a more broad FGFR inhibitors. But currently, it's only an hypothesis. The second proof of concept, it's a rare alteration in HEC, is MET amplification. MET is a ligand that binds to HGF receptor that activate downstream MEK and AKT-mTOR pathway, and it is amplified in a small subset of HEC, 2 to 3% of HEC. A first report from in the lab, it was a report of a patient that was resistant to sorafenib, tyrosine kinase inhibitor, and that was included in a phase 2 in our unit of Avicenne Hospital, using a MET inhibitor, tepotinib, with a complete response after 2 months, and a complete response under tepotinib during more than 1 year. So it was very effective, and we analyzed the primary tumor and the bone metastasis and identified a MET amplification in this patient, explaining the response to treatment. So it's not frequent, 2 to 3% of patients, but it was effective, and the phase 2 was analyzed, and there is 15 patients with HCC treated by tepotinib with 1 complete response, 4 partial response, and 11 disease control. And they searched for MET amplification, and when the tumors was MET amplification, you have more radiological response, complete response, or partial response. So it was recently published. So it's a proof of concept that some of the patients with MET amplification could benefit from a true MET inhibitors that are tepotinib, for example. And a last example of biomarker-guided therapy. We recently published a result of genomic analysis for HEC based on the France Medicine Genomic 2025 program. That is a program that's used in clinical care, genomic analysis, whole genome RNA-seq, for 2 main goals: identification of rare constitutional variants, rare disease, familial predisposition to cancer. I will not talk about that. But second goal was identification of targetable genetic alteration in cancers. And so the idea in oncology, you have or a rare tumor, or a cancer of unknown origin, or a cancer refractory to systemic treatment. You have frozen sample, tumor sample. You could include the patient in the 2025 French Medicine Genomic Program, do whole genome, whole exome RNA-seq, analyze in the molecular tumor board the result, and if an actionable genetic alteration is identified, you could use the target therapy, off-label use of target therapy used in another cancer, or include in a clinical trial that have this a drug directed against the genetic alteration. And it is our reports that we published the last years of the 21st patient with HCC and hepatocellular, including the French Medicine Genomic Program, 20 patients analyzed by whole genome sequencing RNA-seq, mainly on tumor biopsy. And to have between the tumor biopsy to the final result and the beginning of the treatment, it was 2 months. And most of them are metastases with BSCLC stage C, have received several lines of treatment, of systemic treatment. And so genomic analysis was performed in 20 patients with a result in 19 patients. And we identified at least one actionable genetic alteration for 70% of the patient, 14, and 9 patients were treated by a targeted therapy matched to genetic alteration. 3 patients by everolimus due to TC1 mutation, TSC2 mutation, or P10 mutation, 2 progressive disease, 1 complete response. 1 patient for RB2 amplification and high homozygous recombination deficiency score by trastuzumab and olaparib, stable disease. 3 patients for FGF19 amplification by the MEK inhibitor, don't work, trametinib, 3 progressive disease. 1 patient with CDK4 amplification with palbociclib, partial response during more than 2 years. And 1 patient due to abnormal recombination score with olaparib, progressive disease. So some of them have a response or stable disease, some of them don't work. And I just want to highlight 2 examples. I show you what works, but I say to you that some of them don't work with progressive disease. But for 2 examples, partial response in a patient that has hepatocellular, sorafenib, atezolizumab, regorafenib. So after 3 lines of treatment, we do the whole genome sequencing. We identify the CDK4 amplification. We treat by palbociclib, CDK4, CDK6 inhibitor, and we have a partial response during 16 months. The second patient, it was HCC, atezolizumab, sorafenib. So in the 3rd line, we do whole genome sequencing, and we have a TSC2 biallelic inactivating mutation that is known to activate the mTOR pathway. So we use the mTOR inhibitor, everolimus. We have complete response, and now Pr Naon, that treats the patient in the unit, said to me yesterday it was 2 years of complete response in this patient. So 2 years of complete response. So it's possible in some cases to have a biomarker-guided treatment in heavily pretreated patients. And the last 5 minutes, I will discuss liquid biopsy, because one of the problems when you have a tumor biopsy and you do genome sequencing is cell plasticity and when you have progression and the impact of treatment in the genome. It is known that there is modification some of the molecular profile under systemic treatment, sometimes of the histological subtype of the HCC. And so it's difficult to have multiple biopsy. It's possible to do it, but it's difficult. And one of the ways to assess the plasticity of the tumor genome is to use liquid biopsy. And I will talk, so liquid biopsy, it's usually you use peripheral blood, plasma, and I will talk about circulating tumor DNA. Circulating tumor DNA is a small piece of DNA, 100 pair bases, 200 pair bases, released both from healthy cells and tumor cells. So when it's from healthy cells, it's circulating DNA. When it comes from tumor cells, it's circulating tumor DNA. And you could detect, if you sequence this DNA, the mutation that are in the tumor, you could detect this mutation in the blood. So the detection of circulating mutant DNA in the blood is called the liquid biopsy. That is a non-invasive detection of tumor genetic alteration by sequencing the DNA released by the tumor in the blood. And you could detect the mutation, the copy number alteration, amplification, the gene fusion, DNA mutilation. There is various technology to analyze the circulating tumor DNA in the plasma. And I will show you an analysis that we have done on circulating tumor DNA. So it was 229 patients, 60 controlled, chronic liver disease without HCC, 173 patients with HCC with a lot of plasma, 700, because we do multiple tumor sampling, and we search for mutation in the most frequent driver genes, TERT promoter beta-catenin and P53, and 2 rarely mutated genes, but with a hotspot, PIK3CN and FA2L2. We use targeted sequencing for these 5 genes, and for TERT promoter mutation, we use the second technique that is called digital droplet PCR. And we sequenced the DNA in the plasma and compared control patients with HCC, with active HCC at sampling, and patients with a past history of HCC and with plasma during follow-up after treatment. And you can see here that we detect in 40% of the cases in patients with active HCC mutation in the blood. In 40% of the cases in the blood of patients with a past history of HCC, but that have currently mutation detectable and that are associated with a risk of tumor recurrence. And in control, it was a very low level of mutation in the blood. And when you analyze patients with active HCC at imaging, it's the ability to detect the mutation is related to tumor burden. More tumor you have, more DNA you have in the blood, more you detect the mutation, and you can see you detect 60 to 70% of mutation in advanced stages BCLCC, very few in very small tumors, and in BCLC A and B, it's increased in frequency. So first we analyzed early stages to identify if we detect mutation in the blood, if it is associated with prognosis. And we analyze the presence of mutation just before the treatment of patients by radiofrequency ablation. And when you have a mutation in the blood, it is around 1/3 of the cases, 25%, you have a higher risk of tumor recurrence and death. It was associated with prognosis and in multivariate analysis. So mutation in the blood, in the early stage, mutation in the blood is associated with poor prognosis. And it's associated with a higher risk of recurrence. And interestingly, with a higher risk of recurrence, aggressive recurrence, outside Mylan criteria, multiple tumors. So it's not only the fact that you have tumor recurrence, but the pattern of recurrence, multiple tumor in the liver, and sometimes with metastasis. So it was early stage, and for advanced stages, it was at the beginning of atezolizumab treatment. So it's when we analyze the data. So a small proportion of patients was treated by atezolizumab. And you can see that we could detect, if we all the patients treated by with advanced stages, we detect in around 60% of the cases a mutation in the blood, TERT promoter, P53 beta-catenin in terms of frequency. And we have multiple sampling in patients with atezolizumab. And when we have a mutation at the beginning of the treatment, we follow in the blood this mutation and to identify if mutation persists or disappear under treatment. And it was 45 patients treated by atezolizumab. 90 patients have mutation in cell-free DNA at baseline, and you can see the first cure, second cure, the third cure, fourth cure of treatment. And you can see that patients who respond at imaging have a disappearance of circulating tumor DNA in the blood, and patients who have stability. And in contrast, all patients who progressed under treatment have a persistent circulating tumor DNA in the blood. So when you have mutation in the blood as baseline, and when this mutation persists under the first cure of treatment, it was associated with a tumor progression and poor prognosis. And I just give you, to finish, one or two examples of the plasticity and the dynamic of this patient. You remember the tepotinib the tepotinib MET inhibitor with a very high rate of response in this patient. And this patient was treated by sorafenib, progressed under sorafenib, and we detect in green a TP53 mutation in the blood of this patient at the progression under sorafenib. We use a MET inhibitor, complete response, disappearance of the mutation in the blood, and 60 months after, we have progression, and we detect a mutation in TP53, but interestingly, a second mutation in beta-catenin in red that was not identified in the first sample and also in the tumor, and we can think that there is acquisition of a mutation of resistance in this patient and of secondary mutation, at least of beta-catenin. So it was detectable in the blood at the progression, P53, the first mutation, but a second mutation in beta-catenin. And another example, it was a patient include a clinical trial, Nivolep, that you have a biopsy of a tumor, small tumors, and you can see that we identified TERT promoter mutation and TP53 mutation in the tumor. It was treated by neoadjuvant nivolumab, and we do a percutaneous treatment by electroporation and adjuvant nivolumab. And you can see that at the end of the adjuvant treatment, there are appearance of mutation in the blood of P53, beta-catenin and TERT, the same mutation for TERT and P53 that were identified in the tumor, but with a new mutation in beta-catenin. So maybe it's useful to use circulating tumor DNA to detect the progression based on and you detect the same mutation that you identified in the tumor, but sometimes you identified additional mutation that are secondary mutation that occurred when you have progression. So to finish, I think probably in the future, maybe in 20 years, I don't know, you will have something like that. In the future, it is the dashboard of the future multidisciplinary tumor boards, for sure, clinical information, and we discussed during what we want to treatment based on the clinical information, but also something that predict prognosis based on hybrid approach. I think clinical information, pathology will remain, but also radiology and molecular biology. We will use alpha-fetoprotein for sure, but probably circulating tumor DNA, probably conventional and artificial intelligence based analysis of histology and radiology, the molecular report of the tumor, at least for advanced stages, evaluation of the general condition of the patient. It's not only the tumor, but the patient. So it will be something that is integrated, not only molecular biology, that alone is not sufficient, but something that are more integrated to capture precision medicine. And precision medicine is not only tumor precision medicine, molecular biology, but also related to patients and all the different ways to assess tumor aggressiveness. And in conclusion, just to say that genomic FTC maybe in the future, it's I don't want to overstate, there will be potential use for prognosis and diagnostic. Circulating tumor DNA could be interesting. I think we need to validate it in the prospective clinical trial and future biomarker guided clinical trial, and we need to focus on the basic knowledge on genomic alteration, anti-tumor mechanism, and integrate tumor biopsy and liquid biopsy into clinical trial. So there is a lot of work to do, but I'm optimistic. And I would like to thank you for your attention and to thank all the members of the liver unit of Avicenne Hospital and all the members of the lab of the Cadre Research Center of Functional Genomics of Solid Tumor.